So this case that we brought is pretty classic for my vascular practice. Young female, in her 60s, smoker, diabetic, and then from there was just having kind of short distance lifestyle limiting claudication, cramping in the calf, and really just kind of weighed on her from a day-to-day basis. So after utilizing duplex to kind of work up the case, we identified that there was a high-grade stenosis in her SFA. From there, we worked our way to the hybrid suite. From here, it's pretty standard in my OR. Both groins are prepped, contralateral access. When our sheet's up, we'll place a catheter into the visceral aorta, make sure there's no inflow disease. From there, go up and over the aortic bifurcation, park my catheter in the contralateral or the affected extremity femoral artery, and perform the angiogram. From there, in this case, as you can see, the SFA was greater than 90% stenosed, causing a flow-limiting lesion. I then heparinize the patient. My sheath will go up and over the aortic bifurcation for stability. Again, this is a crucial component for my practice, not only for getting the atherectomy device up and over the aortic bifurcation, but also for traversing any occlusive lesions as well. From there, I'll place a spider filter distally into the popliteal, below knee popliteal artery to protect the runoff. And from there, go ahead and proceed with the atherectomy, depending on which Hawk device you choose. But I'll go 4-quadrant, anterior, posterior, medial, and lateral. And if there is a plaque that I'm truly concerned about and it's isolated to one surface or one area of that vessel, again, the directional atherectomy device will allow me to isolate my treatment specifically based off of that lesion. From there, I then utilize a prolonged inflation with the impact balloon, drug-coated balloon path technology. And then from there, usually the case doesn't require anything else. We'll shoot the completion angiogram plus or minus intravascular ultrasound, assessing for any sort of flow-limiting dissections or distal thromboembolic pathology. So this usually is a pretty straightforward case where I only need atherectomy and drug-coated balloon angioplasty to treat this patient, and I don't necessarily need to leave a stent or anything behind.